Welcome to RetinUp, where retina conversations happen. I'm Scott Krzywonos.
And I'm John Kitchens.
We've got a big episode coming to RetinUp today. We are debuting a new segment that's called the Vitreoretinal View, and later we'll be speaking with the coding expert Elizabeth Cifers. She's the founder, owner, consultant, and the nimble problem solver at Elizabeth Cifers Consulting. She's going to share with us some coding changes for 2026. But John, let's finish our conversation from last episode. We were talking about Outlook Therapeutics. They received a complete response letter from the FDA about their BLA for ONS 5010. They were hoping to get approval for a proprietary ophthalmic formulation of bevacizumab indicated for wet AMD. It looks like it's not happening. What does this mean for retina?
Well, Scott, I think it means the status quo stays the status quo. And this is really important because we utilize compounded bevacizumab for so many different things. I mean, first of all, it's incredibly affordable. It's often the first-line therapy for many insurances with tiered therapy of formularies. And we use it for a bunch of off-label indications: myopic choroidal neovascularization, idiopathic choroidal neovascularization, uninsured patients. It just has so much utility. And the real problem with an approved version of bevacizumab is that the FDA, and more specifically the regulators, which I would consider kind of like the sheriffs in town, can come in and can start to tell compounding pharmacies, you can't compound this. And may actually even see compounding pharmacies that just take the step before that and say, you know what, we're just going to stop compounding it because we don't want to get tied up with the FDA and regulators. So it would add a lot of cost, a lot of complexity and whatnot. And so it probably for our specialty, at least for the time being, is a good thing that we're maintaining the status quo.
Is there a chance that a approved formulation of Avastin could have actually resulted in less access to Avastin for patients on an economic basis?
100%. I think that was all our biggest concern, was that was what was going to happen.
Talk me through that. Like, what are the dollars and cents, and how would having, because you would think having an approved formulation would make it easier for patients to have access, but it seems in the sort of odd incentive system that we have, that wasn't actually the case.
Yeah, so Lightneva, which was the brand name of the bevacizumab that they were trying to get approved, most likely was going to be hundreds of dollars. We didn't have a price because it was never approved, so we didn't really know what it was going to be, but it certainly was going to be more expensive than compounded bevacizumab, which runs anywhere from $25 to $50, depending on how you have it compounded, who does it, the needle and syringe that you have it compounded with, and whatnot. So, yeah, you were talking about a significant increase in expense to the system, and something, frankly, that patients wouldn't be able to afford.
You know, what worried me is that you have a situation where even if this were to have been priced affordably such that there was a negligible difference in out-of-pocket costs for patients, who's to say that this company, this drug, isn't acquired by somebody else further down the line who then does jack up the price? And there was just so much uncertainty related with getting approval for an ophthalmic formulation of Avastin. I mean, this is bad for the company, but this could ultimately be good for patient access. The FDA did not specify what additional data would be required. Do you think that there's any chance that they go back to the FDA?
Wow, yeah. So this CRL was issued based off the Norse 8 study. Norse 8 study was a very short study with a primary endpoint at 8 weeks. So they really went for it with this study, and it actually did not show non-inferiority at 8 weeks. It did at 12 weeks. So the study went on to 12 weeks compared to ranibizumab, and so the FDA just said no. So they actually would have to go back and do an entirely new study, which,
Right.
boy, I'll tell you, from an expense standpoint, starts to get really expensive. So I don't know if there's going to be another acquisition. Somebody's going to come in and try and take this over. Remember, Scott, they have an approved product in, I believe, the EU, certainly in the UK.
Mm-hmm.
I do know for a fact that the UK product is more expensive than some of their other branded drugs, and therefore I don't think it's utilized very often over there. So it's an interesting dynamic. It's interesting times for sure.
Yeah, that's funny because Europe does not have access to compounded Avastin the way that American clinicians have access to compounded Avastin. So I was always under the assumption that if they had access to ophthalmic formulation of Avastin, that there would have been wider adoption. But you're saying that there was a price barrier.
Yeah, big price barrier.
That's it for our discussion about Outlook Therapeutics. When we come back, we're going to head to our newest segment, the Vitreoretinal View.
This episode of RetinUp is brought to you by Alcon, committed to investing in solutions that drive meaningful progress in retinal care. Learn more about Alcon's latest innovation in Unity VCS at unityvcs.com and hear how surgeons are experiencing extraordinary.
John, this is our first time on the Vitreoretinal View segment. Why don't you tell the listeners a little bit about what they can expect?
Yeah, Scott, this segment is really focused on surgical retina. A lot of our listeners, the majority of our listeners are vitreoretinal surgeons. And we really want to create a forum where we could talk about current topics and trends in vitreoretinal surgery, be it equipment, be it surgical techniques. We might have a few guests on that are utilizing new equipment, new techniques and whatnot. And so it's really focused on surgeons.
And retina comes from a tradition of surgical innovation. And we were talking earlier, you and I, about how it feels like we're on the cusp of something new, some next generation of surgical equipment. What's the state of play in next generation surgery right now?
Yeah, Scott, it's as a retinal surgeon, it's a very equipment heavy field, and we depend on our vitrectomy machine to basically do a lot of the heavy lifting. It enables us to tackle these complicated cases. It allows us to do surgery safer, more efficiently. And about every decade or so, we see a new wave or iteration of surgical equipment that comes out, the vitrectomy machine, basically. And we're on the cusp of that next wave. And as somebody who's done this now for over 20 years, I've had a chance to see three waves of vitreoretinal equipment come through the pipeline. And every time it is just astonishing the things that we're able to do.
So, what is the most current next gen platform? I think we're looking at the Unity VCS.
Yeah, so we expect that each of the big three U.S. companies, Alcon, Dutch Ophthalmic, Bausch& Lomb, will all have new machines within the next, 2 or 3 years. In this iteration, Alcon's leading the way with the Unity VCS system. It's the replacement to the Constellation system. And it's basically all of Alcon's tech that they've been working on over the last decade or so, packed into a new machine. Alcon took a little bit of a different course with this machine. They've created a Unity VCS that's for vitreoretinal and cataract surgery, and a Unity CS, which is specifically for cataract surgery. So they're kind of launching dual machines. They're sort of brothers in a way, in that an OR can have a Unity vitreoretinal cataract machine and interchange it with the cataract machine if you have a cataract surgeon who likes to run 2 rooms. And then you also you can swing that vitreoretinal cataract machine over, and it can do a full complement of vitreoretinal procedures.
Now, when there's a new platform, what is backwards compatible? Like, do all the instruments still work? Is the interface all that different? Does your profile transfer from your previous platform to your new platform? What still fits and what needs a new outfit?
Yeah, so traditionally everything's new. In 10 years, there's a lot of updates that happen with connectors, with efficiency around lights, laser, vitreoretinal equipment. A lot of these cutters will run off of a dual or a triple pneumatics type system to be able to drive the cutter. The fluidics all change. So basically, you need to think about everything's new. The only thing that stays the same is the forceps, the disposable instrumentation that we use that's not attached to the machine. Alcon, between the release of the Constellation and the Unity, had one of my favorite systems, the 3D heads-up system, the Ingenuity system. And what I really love is that they've been able to bridge that gap. And so the Constellation was retrofitted to work and show your data with the Constellation, and it's going to be upgradable to be utilized with the Unity system. So Alcon's always trying to think about how they make their equipment work better together.
So there's 2 investments if you're going to be an early adopter or an adopter at all of a new platform, which is not just money, but also time, right? Like how much does your workflow change in the OR when you have a new platform?
Well, hopefully very little because these new platforms are always designed to improve efficiency. We saw that with the last generation machines where we had higher cut rates, better fluidics and whatnot. We had smaller gauge surgery that was now much more reliable. The instruments were stiffer, the instruments had better flow, so quicker surgery with smaller gauge, better results for our patients. In this system, what we're going to see predominantly, and I'm going to talk about the Unity because I don't know exactly what's coming from Dutch Ophthalmic or what's coming from B&L, is we see an entire new paradigm shift. We're working now more towards a peristaltic pump, which allows for a flow-based control vitreous system. So you're able to actually precisely control the flow of fluids out of the eye, be it BSS or be it vitreous. That's really kind of the new innovation here, but it still keeps the basic core of the constellation. So if you like more of that Venturi type of vitreoretinal experience, you can flip it over and instantly be working with the Venturi system. So you actually now have two systems in one.
Yeah, I'd be curious if there's going to be a generational difference among surgeons that we see in 10 or 15 years, those who like Venturi versus flow-based surgery.
You know, the thing I love about it though, and you mentioned this earlier, is there a disruption in your workflow? Is there a slowdown? And what we found, and we were involved in the alpha testing and the beta testing, and full disclosure, I'm a consultant for Alcon, but we were involved in all of those testings, and what we found is that it's almost a seamless experience. Yeah, you do need to learn a few different parameters for flow-based vitrectomy, but the equipment, the setup, everything feels so refined. And if you're coming from an Alcon system, I don't think you're going to have much of a disruption. We also did a time and motion study, our practice and practice in Los Angeles. What we found is that there was up to a 30% improvement in setup and in teardown of the equipment, and a 30% improvement in case time. Specifically, some of the innovations around laser really improved case time and whatnot. So hopefully we see enhanced efficiency with this system.
That could be really relevant in an age of declining surgical reimbursement. John, what's next on the horizon for the other two players here? We're talking about Dork/Zeiss and Bausch& Lomb. Do we know what to expect there, or do you know sort of in broad strokes what you and your colleagues are expecting?
Yeah, I think they're going to do a lot of what we're seeing Alcon do here, which is continue to pursue for DORC flow-based vitrectomy. You know, DORC was the forebearer of flow-based vitrectomy with the EVA machine. They really kind of
Okay.
modernized flow-based vitrectomy and have been advancing that technology over the last decade or so. So I think we'll see B&L jump in. I think we'll see refinements on the EVA system on the DORC side of things. I think there'll be improvements in illumination, improvements in laser. One of the things we see Alcon moving forward with is a 4-spot endoprobe laser, which is amazing technology to be able to think about getting pattern laser in a 25 or 27 gauge probe. I think that people will follow along with that from that side of things. And then continued enhancements in the peripherals. We're talking about things like our cannulas and trocars just getting better,
Okay.
wound construction being better, the way we control our fluidics being better. So I think we're just going to see every one of these companies just start to raise the bar, which is going to lead to more efficient surgery, safer surgery for our patients, and hopefully better outcomes.
All right, John. Well, that was our first Vitreoretinal View. We'll be covering surgical topics in this segment in the future. If you, a listener, have a topic that you want discussed, send it over to us at info@retinup.com. Stay tuned for our interview with Elizabeth Cifers. She's the founder, owner, consultant, and nimble problem solver at Elizabeth Cifers Consulting. John, in the fall of last year, we went to the Syncora meeting in Dallas. Elizabeth Cifers was one of the speakers there. She's the owner, consultant, and the nimble problem solver of Elizabeth Cifers Consulting. She's here with us today. Elizabeth, welcome to the show.
Thank you very much for having me.
And Scott, I can tell you for sure, whenever you've got an audit from Medicare or an insurance company, you want a problem solver and you want them to be nimble. So I think that's an apt description of Elizabeth.
When
Thank
she
you.
came off the stage at the Syncora meeting, John, you turned to me and said, let's have her on the show. What was it about the talk that really wanted you to bring Elizabeth on here?
Yeah, so well, I think it's more of the history with Elizabeth. I mean, I heard her talk 3 years ago at the first Syncora meeting, and immediately I said she has to come help our practice. Because I don't care how long you've been in practice or how much time you dedicate to this, you can always be a better biller and coder because it's an always changing field. There's always updates and things such as that. And so we actually hired Elizabeth to come in and help us become better coders as physicians, and she really helped elevate our game. So it's kind of knowing that and then the energy that she brings to something like billing and coding that requires a lot of energy to actually get us engaged. But it's probably the most important part of our practice. You got to realize I'm probably the worst biller and coder that you've ever experienced, and you've actually helped train me. So you can take credit for that. But what is a modifier 25 and when would we use it? And what is a modifier 59? And I'll have to say, I don't think I've ever used a modifier 59. I know a modifier 25 is used all the time in our practice. But what are each of those and when are the right circumstances to use it? What's it do? What is it?
Okay. So let's start with the basic. A modifier is a two either digit alphanumeric code that is appended to a CPT or HCPCS code that adds some color and flavor to the CPT or the HCPCS code. It doesn't change it. It just adds additional information to it. So a modifier 25 states that the office visit is significant and separately identifiable from the same day minor procedure. Basically, it's unbundling the office visit from the procedure, which, as you know, with global surgery, 90-day global surgery, that office visit you would modify if you're doing today or tomorrow surgery with a 57. So it unbundles it out of the global package. And that's
And
the same thing the modifier 25 is doing.
now, most commonly, we're using that 25 with an exam and an injection, right?
Right. Or like a laser for horseshoe tear.
Okay.
I mean, that's a minor procedure as well. And I think people forget that that's also a minor procedure. Technically, epilation by forceps for trichiasis is also a minor procedure, so you need a 25. So what it says is the office visit, that there is a reason you're doing the office visit that's completely not related to the procedure on the same day. Now, so that it translates into what else was going on. What else is the problem that you're addressing that day that the patient has that isn't related? So you have a bucket over here that says this is the problem we're treating, and we have the bucket over here of whatever else is left. And you separate the two out. It's not a decision to inject. It's not, if it's a new patient, that you get your exam and you get your procedure. Modifier 25 doesn't have a new patient, established patient caveat. And that's kind of an urban legend, if you will, that it did. It's
So
never
wait, go back
existed
and
that
say,
way.
what do you mean new patient versus established? Was there some thought that a 25 couldn't be used on new patients or was excluded from that?
That it could be used on a new patient. Because if a patient's new to you, of course you have to examine them to figure out what's going on to make a decision of what you're going to do. It's not a known patient. You don't know their history and anything else. So the caveat that most physicians have worked under for a long, long time that has not been corrected until now is that a new patient, of course you get to do your exam and then the 25 and then your injection or laser for a tear or PRP, whatever that you need to do. That's a minor procedure, but that's actually not true. There is no differentiation between new patient and established patient.
So what you're saying is, let's say I see a wet AMD patient, new wet AMD patient, diagnose them, and I inject them on that day. Do I need to have something else in my list of diagnoses to justify that modifier 25? Or am I not getting paid for that new patient exam?
So it's not only having something in the diagnoses, the exam has to back it up, and there needs to be some indication in the chief complaint for that. So one of my favorite examples is the patient, part of their complaint is reduced vision. Not as clear, not as good, not as whatever. Now, the AMD may be playing into that, certainly, but let's say they also have a pretty significant cataract that you also feel is causing part of the issue, or it could be the fellow eye that you're treating one, the fellow eye really has a pretty significant cataract. So the decreased vision and the finding of the cataract in the exam, and then you address it in the impression and plan, stating, yeah, I think pretty much this could be part of it. Let's send you to Dr. Cataract to have it evaluated for extraction because, this could also be playing in. That would meet modifier 25. Even if it was in the same eye, it's something completely unrelated to what's going on.
I guess our
that you're
best
treating.
example is probably like dry AMD in the fellow eye. You get a wet AMD, one eye, they've got drusen in the other eye. Now you've got your dry AMD in the fellow eye. Now, can you use that over and over? Like, can the next visit that be the same thing and you still bill for a modifier, use a modifier 25 to bill for an exam and injection?
That's where you start getting into some tricky nuance of what the documentation is going to support. If your documentation says drusen or GA on the fellow eye, the non-treating eye, again and again and again with no changes quantifiably, qualifying, quantifying, whatever, adds color into there's more, there's, the GA area is growing, there's something else indicating you're performing the exam. I would never say you didn't perform the exam unless I was in the lane with you and saw that you didn't, but the documentation has to support that exam took place. When you end up with clone notes, basically it's a pull forward or they're identical again and again, it's really challenging to say, oh yeah, you really did address that. Even if the impression and plan indicates the change, the exam looks identical. And since you can grab some of that off of diagnostic testing, that's where it's, what did you say on your interpretations? Where did you get the information? Was it the exam or was it the testing?
So can we put a pin in the idea of repeated documentation for a second? Because that was a big part of your talk at the Syncora meeting in Dallas. You mentioned earlier there's a new emphasis on modifier 25 that they're now, emphasizing a rule that they previously overlooked. And from what I remember in your talk, it was focused on like conjunctions, right? It was like words and if. So what's the refocus here that doctors need to know about?
So the refocus is one, it's not a decision to inject. You cannot plan for a future minor procedure, such as you're going to inject the fellow eye at a future date, whether that's tomorrow, 2 weeks, a month, whatever that may be. That piece of planning a minor procedure goes counter to global billing rules. You can't plan a minor procedure. It's inherently included in. So that's sticky point number one, because it's very common, especially if you're not doing bilateral injections. You plan, left eye today, in 2 weeks we're going to come back and do right eye, whether that's patient's preference, physician's preference, or both. Then you can't plan that future injection. That doesn't count towards today's level of service for the office visit. That is being pretty strictly enforced. That came out in the OIG audit that was published at the end of May of 2025, having to do with the intravitreal injections and modifier 25 on the same day. The other one came out in the Medline Matters in September, which is from CMS, that gave a very muddy paragraph that said to the effect of that if you're doing an exam, you're going to treat one, you do an exam, you evaluate both eyes. If you find a new problem with a new management issue, then you may be able to bill a 25. On reflecting on that from the meeting, and a physician asked me the question, so I let Syncora know when they sent them out to add my new caveat to it. That really is an example, I believe, and I think you could defend, because they said, for example, in this scenario, that what you're looking for is the significant and separately identifiable. It could be something new, or it could be something that worsened that now needs treatment. So the patient has floaters. Okay, now it's turned into a PVD. Okay, now they have something else, a detachment. That's still, the detachment's not the 25, not the greatest example, but you look at a progression of, it was something that wasn't treatable, we're monitoring, and now it's something that we need to do something with, or we're changing treatment plan. It could even just be, that they're a status post cataract surgery. You didn't perform that surgery, but now they have, CME, that you're going to start them on topical drops to see if that helps with the edema before you move on to injection. That's a significant and separately identifiable. So the key here is that it's not that there's been a change, it's that it's being enforced with great rigor.
I mean,
They're
even
not
the
being very
language
kind.
even the language you described may be included, right? Or may be billable. Maybe is not binary.
Because it all depends on what the documentation says. And that's why I would say I think most physicians, the medicine is good. The documentation may not support what you're billing, and it has to. The documentation is the story that you're telling. The CPT codes and the HCPCS codes and the modifiers and the ICD-10 codes that you're putting on the claims, that's all they see. So when they ask for the chart, which will come probably more often than not, that documentation has to tell the same story.
So what are some of the best practices for good documentation, and what are some examples of sloppy documentation? Is it just that copy paste, or are there other examples of bad documentation that might raise a red flag?
Copy paste is absolutely at the top of the list. I see it very often. Not editing properly. So let's say the patient had a cataract that was removed and now they're PCIOL and the diagnosis still says cataract, but the exam reflects PCIOL. Oops, there's a mismatch. So that starts questioning all the documentation. How valid is it? As far as other items, forgetting that you have to have medical necessity actually documented. So you have an AMD patient. We'll go back to your example, Dr. Kitchens. The AMD patient you're going to treat, and you say they have AMD and we're going to use X drug. Okay, what is it that you want to accomplish? The obvious is that you want it to get better, right? You want to decrease edema or fluid, whatever language that you wish to use. But did your chart note actually state that? Or did it just say, hey, we're going to do this injection? What's your goal? What's the outcome that you want to see?
Wow.
Which is,
Yeah.
right.
So you have to have an
So-
impression plan and an anticipated outcome.
Well, you've got to say, and so then on the next visit, it was better, it was worse, it was,
Okay.
the
Yeah.
same, it was suboptimal. We're going to treat again. We want to reduce the edema, the fluid. We want to, retard the GA growth. We want to, what is it you want to happen? And that medical necessity statement is short. Doesn't have to be long, but it needs to be there because otherwise you're making assumptions and that your documentation is telling the story. Well, to you, because you deal with it day in, day out, it is. But most auditors don't know. So either they call everything right or they call everything wrong, depending on how they were trained and, what they understand the process is. I've seen a lot of inconsistent outside auditing from payers. That is very frustrating on my part because you'll see, one claim gigged and another one not, and they're basically identical.
Mm-hmm.
It's different auditors.
I see why this would happen, though, right? Like, John, if you're documenting a medical necessity for giving anti-complement therapy to a GA patient, the only thing you're trying to do is retard the growth of geographic atrophy, right? So I understand why this would be overlooked by
Well, and we
clinicians
give
in
an
a busy
impression
clinic.
and then we give an action. It's not really necessarily a plan. It's more of like this is what it is. This is what we're doing. And we're not necessarily interpreting how the patient's doing in that assessment and plan. It's just, here it is. This is what we do. And I think what Elizabeth's pointing out is that's going to come under greater scrutiny and may not be acceptable. Now, Liz, you mentioned another modifier, and this is one that blows me away. I've never heard of or used a 59. I probably have used it
Really?
because my scribes bill for me most of the time. What is a 59 and when is it used?
So a modifier 59 is a distinct procedure. So if not appended to office visits ever, it's for diagnostic testing and for any sort of procedure, whether it's surgical in the office or in the OR. So an example is that usually these are two codes that are bundled together, meaning that in the National Correct Coding Initiative bundling edits that CMS has, there's some reason you don't normally bill these together. One of the things is a retinal OCT with a fundus photo. Everybody knows you don't bill these at the same time. That's under an NCCI edit. Okay. Now, the caveat is it does state that if it is appropriate, you may append the appropriate modifier. So we're going to leave the testing alone for a second because that's the sticky wicket. That's the part that people are struggling with. So an example might be that you're doing an intravitreal injection in one eye, but the fellow eye has really high IOP. So you're going to tap, bring it down. Those two procedures by CPT code are considered bundled, but they're fellow eyes. So the 59 would go on the intravitreal injection, which has lesser RVUs. It always goes on the lesser RVU. You're unbundling out of the more major procedure. Okay. So that's an appropriate use. Now, with diagnostic testing, we're back into the NCCI rules that state pretty much the eye is the eye. You can't separate out. You can do contralateral. So, but the caveat, the issue with that is that almost all the diagnostic testing that we use in retina, so your OCTs, FA, fundus photos, ICG, they are all inherently, and all except fundus photos state in the code description that they're either unilateral or bilateral. So inherently, it's both eyes. Fundus photo doesn't state unilateral or bilateral. However, it is coded to pay as a bilateral. So all of them are inherently basically bilateral. So if you're appending a modifier 59 to the OCT, a retina OCT, to unbundle it from the fundus photo, or the fundus photo from the OCT, excuse me, then you're saying that there is a distinct, you have two different diagnoses, you have a different issue, you have a separate problem. And that's not really how NCCI reads, since everything's inherently basically bilateral. You would have a really hard time defending. About the only thing I've ever said I could live with, but not ideal, is, let's say you had a nevus in one eye that you wanted to get a good fundus photo and measurements, and you're looking for markers for tumor or whatever, that you documented very well that way, but you had an OCT for a different reason. With the fundus photo, if you only do one eye, you can use yet another modifier called a 52 for reduced services, saying that you're not going to pay me for the full amount. I only did one eye. That's where you could almost argue it's a separate diagnosis, it's well documented, and it has nothing to do with the OCT or the findings that you got from the OCT. That's about the only exception that I kind of hedge on, but it all comes back to documentation.
So in that scenario, if you had a nevus in one eye and you're taking a picture of just one eye, OCT of both, would you use both a 52 and a 59 modifier?
Right. You're going to reduce the service. You have to unbundle it, and then you're going to reduce it.
So two modifiers can exist on the same line.
Yeah. You can have 3 or more, but yes.
Oh
so
God.
It's the order. You have to unbundle first, and then you would apply the reduced service. So you have to get it out of the either bundle, whether that's a global bundle like the 25, or in this case, the edit bundle that you have to separate them from, and then you append any other modifiers like the eye modifier.
So the need for all this documentation that you're talking about, thorough documentation, which will, I assume, cover you in an audit, and we'll get to audits in a second. This all comes on the background of some big policy changes at CMS. And you talked about this again in your talk at the Syncora meeting. Tell us a little bit about the change in strategy here, right? CMS is moving away from a pay and chase model to a prevent and detect strategy. I assume this is because the new administrator of Medicare and Medicaid services? No?
It's actually the switch from pay and chase to prevent and detect started in about 2013. It was published 2014, 2015 under old administration. Yeah, it's old. It's just it's never had teeth.
So what are those two strategies, and what do they mean?
So pay and chase is what we historically know. The physicians bill the claim gets submitted, they pay. If it's wrong, then they chase it down. It's a post-pay audit. It's, a recoupment. It's, oh, you didn't meet it, pay it back. That's pay and chase. They paid it. Now they're going to chase getting back what they shouldn't have paid in the first place because the documentation didn't support it. Over the years, it's slowly morphed through various auditing into now they want to prevent and detect. So this is where we get into AI and machine learning and algorithms that they're using the data to look for anomalies or outliers to say, that looks a little hinky. Let's look at that further, in which case it could end up as a prepay audit that they're asking for the records before they ever pay it. So that's the prevent and detect. So they're detecting an anomaly, they're asking for it before they ever pay, analyze it, and they say, no, it doesn't meet it, or yes, it does. And they pay accordingly from there.
Liz, is this anomaly like just you're using too many 25 modifiers? Is it looking for global trends in your practice, or is it digging in and looking for something else that we, have to be more aware of?
Modifiers are always at the top of the list. As an auditor, when I start an audit, I typically get utilization from the practice for a year. The first thing I do is put it in a pivot table and I start looking for modifiers. and what things they're billed with, what modifiers you're using, what are the codes. And that's how I start picking my charts. As an auditor, I want to find where your risk is. So I need to educate you where your risk is and teach you what, if it's great, if the documentation's good, perfect. If it's not, then where's your risk and what do you need to do to improve that? So it's the same thing, but they're doing it on this grand scale, AI and algorithms, just the computers looking for anomalies, certain code, that whether a 59 is a huge, 25s, I mean, there's a myriad, they're going to look for it. And it's easy to find if you're looking. And then look at the CPT codes, and then you have utilization on top of that, whether it's at the physician level, the practice level, or in the case of retina being bundled into all of ophthalmology, it gets pulled together. But remember, retina isn't the only, or ophthalmology isn't the only one that uses 25s. Other specialties do as well. So they're running into the same sort of thing. It's just we got thrown onto the national stage with the injection and modifier 25 same day in the OIG report.
Suffice to say, it's all modifiers that get you then looked at. It's not really anything else. It's mainly just the use of modifiers.
Modifiers are the first thing that will get the fastest. And it's, proven. I mean, I can literally, you can look at data and start going, yep, there's a problem, and not even look at a claim yet. Because just from knowing and having done this for so long, I kind of know where the bodies are buried. So I know what I'm looking for, and it usually proves out. And again, it's not that I believe the medicine's bad, it's the documentation and not understanding how to use modifiers or what has to be documented is a problem.
So, do I understand correctly that these algorithms are only looking at coding practices themselves and not necessarily at the documentation? Is the documentation the backstop to justify the use of those codes?
Right. That's where you'll either get a prepay or a post-haste audit to ask for the chart. So it's a additional documentation request, an ADR that usually comes from the MAC. If it's a Medicare, if it's a Medicare Advantage or a commercial payer, they just request the documents, and it's just an audit of whatever description. It may just say prepay, postpay.
Do you sense that there's going to be then an increased number of prepay audits like what you're describing? Or is CMS going after, a few examples to make examples of a few practices and let that trickle from there? Like, do you really think that the risk of audit is increased given this strategic shift, or is it just a new way to skin the cat?
It's really easy because you already have targeted what codes appear to be anomalous, modifier or by CPT or even by ICD-10. Let's say you have a GA drug that has an AMD diagnosis, not a GA diagnosis. You've got a mismatch.
So chances are you're not actually going to get maybe audited as much. You just might not get paid as successfully. Is that safe to say, Elizabeth?
I think the risk of audit is always there. I think it's higher now than it was. It's not we're one physician, we're two physicians, we don't have to worry about it. With the algorithms that they have, it's not an if, it's a when. I think that's a given for all of medicine, not just retina. The not getting paid comes back down to documentation. What is your documentation to support? Does it go back to support that story you told with the CPT, HCPCS modifiers in your diagnosis codes? Does it support that story? If it does, you're probably fine. If it doesn't, then what can you learn from that? Where did the documentation fall down? What wasn't clear? Kind of like talking about the medical necessity. Did you explicitly state that you want to reduce the edema or the fluid, or you're trying to squelch the, little blood vessels that are coming up? What was it that you stated your goal is on this? And that is the medical necessity part that gets skipped a lot. It's just assumed, well, of course I'm doing this because of this, but it's not explicitly stated. The payers are looking for any reason not to pay. Their job is to keep their money, cynically. Our job is to get you paid for what you do.
So what are some of your clients doing in response to this? Are they hiring more scribes? Are they training themselves out of bad habits? What are the sort of boots on the ground, the very practical things that your clients are doing to address these changes?
They are willing to look at where their risk is. So first of all, it's not pointing fingers at everybody and so-and-so's fault or this or that. Just that has to stop. It has to be, where are we? Realistically, objectively, what are our problems and where are our risks? Then what do we do with it? So is it physician training of, guys, ladies, you got to stop doing this? Is it educating scribes even more so they can be that stopgap for the physician when they say, oh, put a 25 on it, that the scribe understands well enough that you haven't addressed anything separately. And maybe you have in your head, it just didn't make it down into the chart. Address that, get that on there, and then it can take care. I think a lot of it is slowing down with fee schedule cuts. Even though we get a bump this year, there are cuts at other places, rising cost of living, pay increases for staff. There's this churn mentality that we've got to see more, we've got to do more, we need to bill more, instead of saying we need to be more efficient, we need to be exacting in what we do. So the first time the claim goes out the door, it is accurate. We're not redoing, that's wasteful, it's inefficient. It goes out correctly, it gets paid. If it's denied, the documentation supports it. If it doesn't, then you figure out where did it fail, start again. If it did support it, you appeal the denial. You don't just accept it and roll over and go, oh, no, really, okay, fine, you're right. Because a lot of times payers play games and they deny things that are perfectly legitimate just to see what you're going to do.
Let's talk about audits. Like that day finally comes and you're going to get audited. What are the first steps that you take if you're a busy, let's say, moderate sized retina clinic? You're already busy. Now you have this other homework assignment. Where do you start?
Depending on the type of audit, you may want to seek outside counsel and have it done under privilege, whether you do it internally or not, just so the attorney is aware of the type of audit. If you have a UPIC audit, obviously an OIG audit, a SMRC audit, those probably you might want to alert your attorney that you at least have it, let them have the documentation. They may want to put it under privilege. They may want an outside auditor to do the audit so you know what the findings are, at least from that perspective before you send it in. You have to make sure that you've read what they're saying, when it is due, what information that they want, and then get it in there timely. Don't delay. If you can't meet the deadline, so it got lost someplace in the office and it hits your desk and it's due in 3 days, then there's a phone number that you can call and say, this just hit my desk. I have no idea. I need an extension. They're usually very kind about doing that. If it's, honestly, things happen. I've had clients that have done exactly that, and they've then sent them to me. They want me to do a pre-review, and I submit for them to make sure that everything is done and labeled correctly. So when it gets there, it's all good. Don't panic. It's going to happen. They will usually find at least something wrong. It may be on their part that no, it is supported, in which case appeal. Absolutely. It could be that, it could have been clearer, but this is what I meant by stating they have AMD and I'm going to use this drug. This is what I'm trying to do. Explain it. They may let it slide. And basically the documentation could be better. We're working on this. That's part of the compliance program, not a plan. It's something that should be living and breathing and working all the time to improve. It's learn from it. Don't panic. Don't finger point. Everybody makes mistakes. That happens. And move forward from it. When you get the findings, take it seriously, read through it. If you need to appeal. If what they're finding and their explanation makes sense, or you have questions, usually they have a person you can contact, or there'll be a debrief with the payer to say, hey, I don't completely get this. And they'll go through it with you and help you. That's like the targeted probe and educate, the TPE with CMS, with the MACs. That's exactly what it's designed for. It's a targeted probe, and then they're going to educate on the findings. There may be another round, but they want to see after they educated you that you've improved. That's the goal, is to have you improve, which is why they do it that way. Not all audits are that kind. They're not designed that way. Some are designed to absolutely recoup whatever they can recoup, or as in the case of UPIC, they frequently will make law enforcement referrals. So
What is UPIC?
I knew you were going to ask me that. It is let's see if I can pull it up.
It's all right. You can generalize it. Like, what does it mean? It's Medicare, or is it?
Yeah, these are all Medicare contracted auditors. The UPIC is a very specific targeted. You have been referred there by CMS, and there is a finding somewhere within your data that they suspect fraud.
Okay, so that's not just
It's kind of the bottom line.
like 25 or 59s. That's more of like, hey, we think you're
Yeah.
using drug that you don't actually like. That's splitting vials or treating people that don't exist, that kind of stuff.
Right. For it to get to that level, usually, yeah, but it's a step below the OIG coming through your door. So you pick audits you just don't want. Are they the end of the world? No. But is it, you know, oh, we won't worry about this? No. Pay attention. And the SMARC audits are also, you don't really want them, but they're very targeted. Like the SMARC audit going on right now with Noridian is the Modifier 25, same day intravitreal injection, only on the established I codes, the 92014 and the 92012. That's a SMARC. They're looking at it. They were directed by CMS to do that. So that's what they're doing. Not as dangerous. They'll have findings. You'll get feedback. And, you'll have to recoup unless you can appeal anything that they found wrong and win.
Is there a way to stress test a practice? Can you run an internal audit? Is that what you do? Is that your role in this ecosystem?
I'm an external auditor, but so if you do internal audits, that's great. One cautionary is when you have somebody doing the internal audits that knows what the physician means by certain documentation, that's dangerous.
We'll just reinforce what
Because-
they're already doing, right?
Right. Because then an external auditor, when I look at it, if I'm defending an audit, I'll pull out all stops. I know what you mean, and I'll tell them so and go, yeah, the documentation could be better, but this is what, connect the dots. This is what this means. Go ahead and let them pay. We'll work on documentation. If I am performing an audit to let you know where your risk is, I'm not going to be kind. I am going to be very letter of the law and by the book and go, no, that does not support the medical necessity. You didn't tell me what you hope is the outcome of doing this procedure or injection. It doesn't meet it because objectively it doesn't. So so anytime you do internal, that's great. But every few years, whoever you choose to use, there should be an external audit just to make sure that your internal is holding up like it should. And it may be that you have a great internal auditor that's, very objective and does not assume what the documentation means.
Elizabeth, where can people find out more if they're interested in what you do or information that you provide? Is there a good website that they can go to?
ElizabethCifersConsulting.com. And I do a biweekly article that I push to a link to LinkedIn, but if you sign up for free, it'll come right to your email inbox. Coding, billing, documentation, practice management, compliance. My website has a lot of information on there that you can peruse, set up a free 15 or 30-minute consultation, see if it's a point to work together, or if you find what you need, that's great too.
And give us that website one more time. Spell your last name for us.
It's Elizabeth Cifers, Cifers, Consulting.
All right. Well, Elizabeth Cifers is the owner, consultant, and the nimble problem solver of Elizabeth Cifers Consulting. Elizabeth, thanks for joining us. All right, everyone, we will see you in 2 weeks for our Angiogenesis 2026 preview. In the meantime, subscribe to our newsletter, visit RetinUp.com, or scan the QR code on your screen so that you can get updates about when we have a new episode. And you can interact with RetinUp by leaving a comment on this episode on YouTube. We might read it on the air or respond to it. And if you have a mailbag question, send a voice recording to info@retinup.com. You can hear John's thoughts on what's happening in retina, what's happening in ophthalmology, what's happening on the business side of things, or you could even get some career advice or just pick his brain about anything in general. For now, I'm Scott Krzywonos. That was John Kitchens.